start together our first conversation.
Good evening and a very warm welcome to everyone. This is Batul from IJCP, the moderator for today's session, and I would like to welcome wholeheartedly everyone to our platform for the better exchange of knowledge that is going to be shared by our stalwart who is present here with us today. Well, she needs no introduction at our platform, but it's our pleasure and honor to introduce her. She is none other than the very renowned obstetrics and gynecologist, Dr. Veena Shinde, ma'am. Ma'am is MD in obstetrics and gynecology, DGO, PG in Assisted Reproductive Technology and consultant at Shinde's Medicare Hospital and Spandan IVF, Mumbai. With ma'am wonderful insights, we are going to talk about the topic for today, which is counseling on family planning. Before moving on to today's topic, let us have a brief look on what the topic says. So the topic about today is going to empower the webinar where we delve into the crucial role of counseling in family planning decisions. This webinar is designed to provide valuable information, foster upon discussions, and equip our viewers with the knowledge and tools needed to make informed choices about family planning. Key topics that are going to be covered are the importance of family planning counseling, understanding the significance of counseling in making informed and empowered decisions, exploring the impact of effective communication in the family planning. Now, without any further delay, I would like to welcome ma'am at our forum and would like to hand over the session to her for her precious talk to begin. Ma'am, over to you.
Very good evening to everybody. Family planning counseling. Next. Population explosion is a big issue in developing countries like India. This has led to an increase in the poverty and unemployment. The population has grown from 350 million at the time of independence to 1,210 million by 2011, an increase of 181 million over the last decade. Next. Eligible couples. Definition: a currently married couple wherein the wife is in the reproductive age group, that is 15 to 49 years of age, approximately 150 to 180 eligible couples per 1,000 population in India. These couples are in need of family planning services. The eligible couple registered is maintained and updated by ANM, MPHW, and ASHA. Next. Couple protection rate, CPR. It is an indicator of the prevalence of contraceptive practice in the community. Definition: the percentage of eligible couples effectively protected against childbirth by one or the other approved methods of family planning. NCR equal to 1 can be achieved only if the CPR is more than 60%. Newly married couple needs house, education, career, and finance. Next. Principles and conditions necessary for effective counseling. Privacy. Find a quiet place to talk. Take sufficient time. Maintain confidentiality. Conduct the discussion in a helpful atmosphere. Keep it simple. Use words that people in your village will understand. First things first, do not cause confusion by giving too much information. Say it again. Repeat the most important instructions again and again. Use available visual aids like posters and flip charts, etc. Skills and characteristics of a counselor. Respect the dignity of others. Respect the client's concern and ideas. Be non-judgmental and open. Show that you being an active listener. Be empathetic and caring. Be honest and sensitive. Family planning counseling, the gather approach. Greet the client respectfully. Ask them about their family planning needs. Tell them about different contraceptive options and methods. Help them to make decisions about choices of methods. Explain and demonstrate how to use the methods. Return, refer, schedule, and carry out a return visit and follow up. Greet. G. Greet them in a respectful manner and introduce yourself after offering seats. Ask them how you can help them. Tell them that you will not tell others what they say. If the counseling is in a health institution, you have to explain what will happen during the visit, describing physical examination and laboratory tests if necessary. Conduct counseling in a place where no one can overhear your conversation. Ask the clients about themselves. Help them to talk about their needs, doubts, concerns, and any questions that they might have. Explain that you are asking for this information in order to help you to provide appropriate information so that they can choose the family planning method which is best for them. Keep questions simple and brief. Look at her, them as you speak. Tell them about family planning methods. Tell them which methods are available. Ask which methods interest them and what they know about the methods. Briefly describe each method of interest and explain how it works, its advantages and disadvantages, and possible side effects. Help them to choose a method. Ask what the spouse partner likes and wants to use. Ask if there is anything they cannot understand and repeat information when necessary. When the chosen method is not safe for them, explain clearly why the method may not be appropriate and help them choose another method. Check whether they have made a clear decision and specifically ask, what method have you decided to use? Explain how to use a method. Ask the client to repeat the instructions. Describe any possible side effects and warning signs and tell them what to do if they occur. Ask them to repeat this information back to you. Give them printed material about the method to take home if it is available. Tell them when to come back for a follow-up and visit sooner if they wish or if side effects or warning signs occur. Appoint a return visit for follow-up. Ask the client if she or they still using the method and whether they have been having any problems. Ask if there are any side effects. Reassure the clients concerning minor side effects. Explain that side effects are not dangerous and suggest what can be done to relieve them. Refer for treatment in case of severe side effects. Ask the client if they have any questions. Rights of the couple. Information to learn about the reproductive health, contraception, and abortion options. Access to obtain services regardless of religion, ethnicity, age, and marital or economic status. Choice to decide freely whether to use contraceptive and if so, which method. Safety to have a safe abortion and to practice safe, effective contraception. Privacy to have a private environment during counseling and services. Confidentiality to be assured that any personal information will remain confidential. Dignity to be treated with courtesy, consideration, and attentiveness. Comfort to feel comfortable when receiving services. Continuity to receive follow up care and contraceptive services and supplies for as long as they are needed. Opinion to express views on the services offered. Type of communication. Relational communications, interpersonal communication in the healthcare setting as it relates to both the formation of a positive and therapeutic relationship between the provider and the patient. Task-oriented communication, ability of healthcare providers to successfully communicate essential information about diagnosis and treatment plans. Relational communication, do's and don'ts. Develop appropriate level of closeness with the patients in order to foster the therapeutic relationship. Build trust, including respectful addressing patients concerning about contraceptive methods. Work to optimize decision-making dynamic, including incorporating aspects of shared decision making such as focusing on patient preferences for features of contraceptive methods. Don'ts. Don't dismiss patients' concerns. Don't pressure women to use a specific method. Don't assume that efficacy is the only or most important contraceptive feature that should be factored into choice of a method for all women. Do's. Task-oriented communication. Offer adequate evidence-based counseling about side effects. Anticipate and address barriers to consistent and correct contraceptive use. Ensure advanced provision of emergency contraception to do all sexually active women. Address perceptions of low susceptibility to pregnancy. Don't encourage women to be concerned about the potential for side effects for which there is no evidence of an association with a given method. Don't neglect to consider role of limited health literacy and numeracy on understanding of contraceptive efficacy. Don't create barriers to switching methods if a patient is dissatisfied. Don't use abstract concepts such as percent or relative risk when communicating about risk and contraceptive effectiveness. In the contraceptive counseling literature, there appears to be a tension between prioritizing patient autonomy in the choice of a method and the desire to encourage women to use highly effective methods. Shared decision making lies between two poles: informed choice, shared decision making, directive counseling. New apps for whose medical eligibility criteria for contraceptive use. WHO MEC Wheel app. You can download it. Pregnancy counseling, maximizing the gains for maternal and child health. What is preconception care? An integral part of primary care for women of reproductive age. Provision of biomedical, behavioral, and social health interventions to women and couples before conception occurs. Provides an excellent opportunity to counsel patients about maintaining a healthy lifestyle and minimizing health risk. During adolescence and before pregnancy, birth, postpartum, newborn, maternal health, infant health, and childhood. Why preconception counseling? 4 out of 10 women report that their pregnancies are unplanned. Maternal undernutrition and iron deficiency anemia increase the risk of maternal death, accounting for at least 20% of maternal mortality worldwide. In 2010, 58,000 newborn babies died from neonatal tetanus. Female genital mutilation increases the risk of neonatal death, including stillbirths, by 15% to 55%. Perinatal deaths are 50% higher among children born to mothers under 20 years of age, compared to mothers aged 20 to 29 years. Up to 35% of pregnancies among women with untreated gonococcal infection result in low birth weight infants and premature deliveries, and up to 10% result in perinatal death. In the absence of interventions, rates of HIV transmission from mother to child are between 15 and 45%. Estimates indicate that eliminating smoking before or during pregnancy could avoid 5 to 7% of premature related deaths and 25-24% of cases of sudden infant death syndrome. Why preconception counseling? Adverse pregnancy outcomes remain a prevalent health problem. 12% of babies are born premature, 8% with low birth weight, 33% have major birth defects, 31% of women giving birth suffer pregnancy complications. Risk factors for adverse pregnancy outcomes remain prevalent. Among women of reproductive age, smoking, obesity, teratogenic drugs, pre-existing medical conditions like diabetes. Need for planned pregnancy. Planned pregnancies are seldom planned with a healthcare provider. Indian women usually visit their doctors only when they are already pregnant, ignoring the basic concept of preconception care. Globally, 38% pregnancies are unplanned and unintended. In India, the number of crosses over 50%. For this reason, all women of childbearing age should be offered preconception care and counseling. Planned babies are more healthier than unplanned babies. Goal of preconception counseling: improves and manage maternal health conditions, improves and manage early fetal development, reduces the risk of adverse health effects for the woman, fetus, and neonate, reduced maternal morbidity and mortality, patients with low birth weight, premature birth, and infant mortality, encourage emotional well-being, address modifiable risk factors. Areas addressed by the preconception care package: nutritional conditions, vaccine preventable diseases, genetic conditions, environmental health, infertility, subfertility, female genital mutilation, too early, unwanted, and rapid successive pregnancies, sexually transmitted infections, human immunodeficiency virus, interpersonal violence, mental health, psychoactive substance use, tobacco use. Type of pregnancy counseling. Because health status and risk factors can change over time, pre-pregnancy counseling should occur several times during a woman's reproductive lifespan. It leads to increasing her opportunity for education and potentially maximizing her reproductive and pregnancy outcomes. It can be performed by the obstetrician gynecologist of an infertile patient before referral to a reproductive endocrinologist, further streamlining patient education. Family planning and pregnancy spacing. Family planning is a foundational aspect of pre-pregnancy counseling. Counseling patients about optimal intervals between pregnancies may be helpful to reduce future complications. Women should be advised to avoid inter-pregnancy intervals shorter than 6 months and should be counseled about the risk and benefit of repeated pregnancies sooner than 18 months. For infertile women planning to use assisted reproductive technology to become pregnant, a pregnancy interval of less than 18 months but greater than 6 months may be advisable. An ovulatory woman younger than 35 years who desires pregnancy and does not have a clearly identifiable risk factor for infertility should be evaluated if she has not become pregnant after 12 months of unprotected intercourse. A woman who is 36 years old and older should be evaluated after 6 months. For an anovulatory woman and those who review of medical, surgical, and psychiatric histories. Chronic medical conditions such as diabetes, hypertension, psychiatric illness, thyroid disease have implications for pregnancy outcomes. It should be optimally managed before pregnancy. Screening may be appropriate for patients with high risk, example, age greater than 30 years, morbid obesity, history of pregnancy loss, preterm delivery, or infertility. Review of current medications. All prescription and non-prescription medications should be reviewed during pre-pregnancy counseling. It should include nutritional supplements, herbal products that patients may not consider to be medication use but could affect reproduction and pregnancy. Medication with potential teratogenicity should be reviewed and the specific risk of each individual medication discussed in detail. Importance of reliable contraception should be emphasized when a patient is taking potentially teratogenic medications. Lowest effective doses of the safest medication should be used wherever it is medically reasonable to do so. Review and family genetic history. A genetic and family history of the patient and her partner should be obtained. This may include family history of genetic disorders, birth defects, mental disorders, and breast, ovarian, uterine, and colon cancer. Women who present for pre-pregnancy counseling should be offered screening for the same genetic conditions as recommended for pregnant women. Couple of risk of having children with specific genetic diseases can be counseled about the disease, inheritance, and course, and offered referral for potential interventions such as pre-implantation genetic testing. Immunizations. Women of reproductive age should have had their immunization status assessed annually for Tdap, measles, rubella, hepatitis B, and varicella. Tdap vaccine should be given to all women during each pregnancy between 27 to 36 weeks, regardless of the pre-pregnancy immunization history. Vaccination for rubella and varicella should be given at least 28 days before pregnancy or in the postpartum period not previously given. Some advanced reproductive age patients may wish to reproduce and hence those aged 50 years and older should also be vaccinated against herpes zoster. Infectious disease screening. Assessment of the need of STI screening should be performed at the time of pre-pregnancy counseling. Gonorrhea, chlamydial infection, syphilis, and human immunodeficiency virus should be screened for bowel on age and risk factors. Counseling to reduce STI should be provided. Those of high risk of tuberculosis should be screened and treated appropriately before pregnancy. Infectious disease screening. Much attention has been given to educational programs to reduce maternal Toxoplasma gondii infection and thus congenital toxoplasmosis. Patients with potential exposure to certain infectious diseases such as Zika virus should be counseled regarding travel restrictions and appropriate waiting time before attempting pregnancy. Individuals with HIV. All reproductive age patients living with HIV should receive pre-pregnancy counseling if considering pregnancy. Pre-pregnancy counseling should include a detailed discussion of interventions to reduce the risk of perinatal transmission, ways to optimize long-term health, and the possible effects of antiretroviral medication on the fetus. Artificial insemination is the safest way for an HIV-infected couple to become pregnant while minimizing the risk of HIV transmission to an HIV negative partner. Individuals with human immunodeficiency, pre-pregnancy administration of antiretroviral presence, ponderance, pre-exposure prophylaxis for HIV uninfected partners may offer an additional tool to reduce the risk of sexual transmission. The choice of antiretroviral therapy in women of childbearing capacity should take into consideration the regime's effectiveness, the woman's hepatitis B status, the teratogenic potential of the medications, potential drug interactions, and possible maternal and fetal adverse outcomes. Substance use assessment. All patients should be routinely asked about their use of alcohol, nicotine products, and drugs, including prescription opioids and other medications used for non-medical reasons. Adverse effects associated with smoking during pregnancy include intrauterine growth retardation, placenta previa, abruptio placenta, decreased maternal thyroid function, premature rupture of membranes, low birth weight, perinatal morbidity, and ectopic pregnancy. Substance use assessment. Children born to women who smoke during pregnancy are at increased risk of asthma, infantile colic, and childhood obesity. Pregnancy appears to motivate women to stop smoking. 46% of pre-pregnancy smokers quit smoking directly before or during pregnancy. Alcohol use patterns should be determined and patient counseled that there is no safe level of type of alcohol used during pregnancy. Fetal alcoholic spectrum disorders are the most severe result of prenatal drinking and are associated with central nervous system abnormalities, growth defects, and facial dysmorphia. Substance use assessment. Alcohol-related birth defects include growth deformities, facial abnormalities, central nervous system impairment, behavioral disorders, impaired intellectual development. Brief behavioral counseling interventions can reduce the risk of alcohol-exposed pregnancy. Marijuana is used by an estimated 2 to 5% of pregnant women. Patients who are contemplating pregnancy should be encouraged to discontinue marijuana use. Exposure to violence, intimate partner violence, and reproductive and sexual coercion. Screening for intimate partner violence should occur during pregnancy counseling. Sexual coercion includes a range of behavioral that a partner may use related to sexual decision making to pressure or coerce a person to have sex without using physical force. The most common forms of reproductive coercion include sabotage of contraceptive methods, pregnancy coercion, and pregnancy pressure. If ongoing abuse is identified, assessment of the immediate safety of the patient and her family should be ascertained and community resources for victims should be provided. Assess nutritional status. Female pre-pregnancy folic acid supplements should be encouraged to reduce the risk of neural tube defects. For average risk, women supplementation with 400 micrograms per day is adequate. Most prenatal multivitamin contains adequate amount of folic for average till women. For average risk women, supplementation with 400 micrograms per day of folic acid is adequate. Most prenatal multivitamin contains adequate amount of folic acid for average risk women. Prenatal vitamins use also is associated with a lower risk of miscarriage. Patients who are at a risk of eating disorders should be screened and counseled. Patients with malabsorptive gastrointestinal disease, bariatric surgery, or those on a vegan diet may require vitamin and mineral supplementation. Achieving and maintaining a healthy body weight. Patients should be encouraged to try to attain a BMI in the normal range before attempting pregnancy. Abnormal high or low BMI is associated with infertility and maternal and fetal pregnancy complications. The reproductive risk of obesity include but are not limited to infertility, miscarriage, birth defects, preterm delivery, gestational diabetes, gestational hypertension, cesarean delivery, and thromboembolic events. Obesity also increases the risk of non-reproductive diseases, including stroke, heart disease, certain types of cancer, arthritis, high cholesterol, hypertension, and diabetes. Pregnant women with low BMI are at a risk of having small for gestational age fetuses and low birth infants. Weight should be optimized before woman attempts to become pregnant. Assess exercise and physical activity. Regular physical exercise improves cardiovascular health, reduces obesity and associated medical comorbidities, and improves longevity. Patients should exercise moderately at least 30 minutes a day, 5 days a week, for a minimum of 150 minutes of moderate exercise per week. These levels of exercise are recommended in pre-pregnancy, during pregnancy, and in postpartum women. Dietary modification. Assess exercise and physical activity. Competitive athletes require frequent and closer supervision because they tend to maintain a more strenuous training schedule throughout pregnancy and resume high-intensity postpartum training sooner. Competitive athletes should pay particular attention to avoiding hyperthermia, maintaining proper hydration, and sustaining adequate caloric intake to prevent weight loss that may adversely affect the fetal growth. Lifestyle interventions. As you can see, the diet, time restricted eating less than 10 in per day, and typical start of maternal life. Assess for teratogens and environmental occupational exposures. There are reproductive and pregnancy risks associated with environmental pollutions, workplace teratogens, and endocrine disruptors. Patients can be educated regarding the evidence of exposure to toxic agents and when necessary referred to occupational medicine programs, providing guidance and information on environmental hazards and protecting women from unnecessary radiation exposure in occupational, environmental, and medical settings. Assess for teratogens and environmental and occupational exposures. Avoid unnecessary pesticide use, providing alternatives to pesticides. Inform women of childbearing age about levels of methyl mercury in fish. Employment sections at particular risk of potentially hazardous exposures during pregnancy include agriculture for pesticides, manufacturing, organic, solvents and heavy metals, dry cleaning, solvents, healthcare, biologics, and radiation. Pregnancy rating. Women should be counseled to seek medical care before attempting to become pregnant or as soon as they believe they are pregnant, to aid in correct dating and to monitor by any medical conditions in which treatment should be modified during pregnancy. Correct first trimester pregnancy rating provides value in managing potential subsequent pregnancy complications and indications for delivery. Preconception care strategy. Assess the strengths and weaknesses of the preconception care system in place. Create nutritional awareness and treatments to ensure protected commitment. Leverage on existing public health programs. Preconception care implementation strategies. About the intervention package, delivering the intervention package, explore, motivate ways and channels in delivering preconception care interventions. Moderate financial resources, and mobilize them, establish a plan for monitoring and evaluation, maximize the gains for the maternal and child health, identify target population, strengthen the human resources. Thank you.
Thank you so much, ma'am. Thank you for such a wonderful talk and for such enriching presentation that you have shared with us on our platform. Thank you so much for that. We have received two questions from the participants. So with all your due permission, I would like to put across those questions to you.
Yes.
And just give me a minute, ma'am. So the first question is related to what legal and ethical considerations should healthcare providers be aware of when prescribing contraceptives?
See, in our country, any girl who is below 18 years of age should not be indulging in sexual activities. In case she gets pregnant, she goes under the POSCO Act. So we should be careful when we are dealing with small girls below the age of 18. Although some of our girls in the villages get married at 15 years of age, once they are married, then they don't come under the POSCO Act. But if they are unmarried, they come under the POSCO Act. So we should be careful. Basically, their nutritional status, their vaccination status, and as it was discussed that they should be having education, they should be having a source of income, they should be having a house, and we must focus and we must enlighten them about the difficulties they will face if they are not healthy.
Thank you so much, ma'am. Thank you for answering that question. We'll move to the next question. And the next question is related to the patients or at higher risk of STIs, sexually transmitted disease. So are there any specific considerations for that?
If they are given vaccinations for the cervical cancer prevention, generally the vagina becomes quite healthy and chances of STIs reduce. In my own practice for last 24 years, we have been using the cervical cancer vaccine, and that has very nicely reduced the infection rate. Also, using of sanitized and proper bathrooms and proper hand wash helps. Uh, Condoms are very useful in preventing hepatitis and HIV as a barrier contraceptive. So we should encourage the girls and enlighten them so that they are more careful when they are indulging in premarital sex.
Okay. Thank you so much, ma'am. Thank you for answering that question. We'll move to the next question. And the next question is related to available options for emergency contraception and how do they work?
The pill 72 is a double dose of progesterone that prevents implantation of the fetus of the embryo, but it should be taken within 72 hours of unprotected sex. Sometimes it can fail. So it is clearly written on that you see your doctor after you eat the pill. Also, IUCD can be inserted within 4 days of unproductive sex. That also helps in preventing an implantation. So these things are available and should be explained to the patient, and patient must come for a checkup even if they have taken this emergency contraceptive, because it is not foolproof.
Thank you so much, ma'am. Thank you for answering that question. We will move to the next question. And the next question is related to the key elements of effective patient counseling on family. What are the key elements of effective patient counseling on family planning?
A dignified conversation with the patient, and you should be able to win their confidence, and they should be able to understand everything. We should explain to them and ask them to explain to us, and repeatedly tell them till they have understood how to use the contraceptive. and you should have follow-ups. If they have any difficulties, they might feel ashamed to ask, but we have to out of the way go and ask them whether they have understood or not.
Thank you so much, ma'am. Thank you for answering that question. Last question for today's session before we conclude, and the question is related to advising adolescents. So, what considerations should be made when advising adolescents on contraception?
See, when we are addressing adolescents, today many of the adolescents face polycystic ovaries. So we have to counsel them on healthy eating habits, on exercise, and how to prevent infections and how to prevent pregnancy. All these aspects must be looked in when we are teaching adolescents and explaining to them. Also, their genital tract and the different parts of their body should be explained to them so that nobody can exploit them and they are confident and they know what they are doing.
Thank you so much, ma'am. Thank you for answering that question and all the other questions for our viewers and making them understand the topic better. Thank you so much for that. And I would also like to thank all our viewers for their ardent participation that they have shown by staying tuned with us throughout the session and putting across such interesting questions to us. And I would also like to thank you, ma'am, for taking out your valuable time and for being here at our platform. Before we conclude, any last comment from your end?
I think it is very important contraception and education of adolescents. And there are lots of health schemes that the government has provided, but we should be able to reach out to the masses. And a healthy woman and a healthy nation and a happy and a prosperous nation should be built with the help of doctors, counselors, and health workers.
Thank you so much, ma'am. Thank you. Thank you. With this, we are concluding the session here for today. Until next time. Thank you so much for your valuable words, ma'am.
Thank you.